Okay, so let's unpack this. I want you to picture something genuinely wild because
Yeah.
before you were even born, during the 6th week of your fetal development, your gut was growing at this staggering, just explosive rate.
Right, it's outstripping the rest of the body.
Exactly. It was growing so fast that it literally ran out of room inside your tiny body,
Yeah.
and it actually herniated outside of your abdomen, just spilled right out.
Which is an incredible mental image.
Right. And then around the 10th week, it has to be pulled back in. But, I mean, it could just get shoved haphazardly back into the cavity. It had to undergo this incredibly precise 270-degree counterclockwise rotation.
It is honestly a phenomenal mechanical marvel. And what's fascinating here is that, we tend to look at the small bowel today like the end result of that whole complex rotation, and we just dismiss it.
Yeah, like it's just a passive plumbing pipe.
Exactly, a neat little tube that food travels through. But when you examine the clinical notes and the medical foundations we're diving into today, you realize it is so much more than that. I mean, it is a brilliant, highly active, continuously regenerating ecosystem.
It really is.
It balances, nutrient absorption, heavy-duty immune defense, and sheer mechanical force all at once.
Which is exactly our mission for this deep dive.
Yeah.
Because we are taking this massive stack of highly technical medical material, stuff covering embryology, anatomy, histology, pathology, and we're translating it into a shortcut for you.
Breaking it down.
Yeah, so you can really understand this 6-meter-long processing plant that's just coiled up right in the center of your abdomen.
All right.
And to get how it works, we really have to look at that initial blueprint.
The fetal development.
Right, because that 270-degree rotation, I was trying to visualize it while reading the sources, and it sounds like, okay, imagine trying to perfectly coil a massive, heavy-duty garden hose into a tiny, cramped cardboard box without creating a single kink.
That garden hose analogy, actually, it captures the stakes perfectly because the gut rotates around this central axis called the superior mesenteric artery, or SMA.
Okay.
And if it twists wrong during development, you get something called malrotation, which basically means that heavy hose is primed to kink later in life, potentially shutting off its own blood supply.
Oh, wow. That sounds dangerous.
Very. But, assuming it coils correctly, you end up with an average of 6 meters of bowel, sometimes up to 9 meters, and it's all distinctly zoned. First up is the duodenum, which is surprisingly short. It's only about 25 centimeters.
Yeah, the notes break the duodenum down into 4 distinct parts. And it is absolutely packed with anatomical landmarks that, honestly, they sound a bit like Harry Potter spells to me.
Right, the Latin names.
Yeah, like they mentioned the ampulla of Vater and the ligament of Treitz. What actually are these structures? Like, what are they doing?
Well, think of the ampulla of Vater, which sits right there in the second part of the duodenum. Think of it as a major plumbing junction. It's the exact spot where the foregut meets the midgut. But more importantly, it's this little nozzle where the gallbladder and the pancreas dump all their heavy-duty bile and digestive enzymes right onto the incoming food.
Oh, so it's like a car wash spraying the suds on.
Exactly. It's where the chemical breakdown really kicks into high gear. And then by the time you reach the fourth part of the duodenum, you hit the ligament of Treitz.
The other spell.
Right. And this is basically a structural suspender strap. It firmly anchors the end of the duodenum right up to the diaphragm, holding that whole junction in place before the bowel really gets loose and mobile.
Okay, I see. And after that suspender strap, we hit the vast majority of the small bowel, right? The proximal 2/5 is the jejunum, and the distal 3/5 is the ileum.
Correct.
And the notes have this J versus I concept, which I thought was fascinating because it really shows how form follows function.
It's a classic medical school comparison, yeah.
Right, because the jejunum has these prominent circular folds called plicae, a wider tube, thicker walls, and these really long blood vessels. But then you get down to the ileum, and the folds are really sparse. The tube is narrower, and it's surrounded by way more fat. Why the drastic design change?
It really just comes down to the workload. I mean, the jejunum is the heavy lifter of nutrient absorption. It needs those prominent, deep folds, the plicae, to create a massive amount of surface area.
To catch all the food.
Exactly. It needs a thick wall and these extensive long blood vessels, which are called vasa recta, to physically haul massive amounts of carbohydrates and proteins out of the tube and into your bloodstream.
Okay, so it's the busy port city.
Right. But by the time the food reaches the ileum, further downstream, the heavy lifting is mostly done. So the ileum narrows out, it gets a fattier structural support in its mesentery, and it shifts its focus.
As to what?
Immunity. It houses these dense clusters of immune tissue called Peyer's patches. So it acts as an immune surveillance checkpoint, basically monitoring gut bacteria before the remaining waste hits the colon.
Wow. So that's the macroarchitecture. But to really understand this 6-meter highway, we have to, like, zoom in on the microscopic workforce actually pulling the nutrients out. The lining of this tube is essentially a bustling microscopic city, isn't it?
Oh, it's heavily specialized. You have the enterocytes, which are your standard factory workers, just absorbing the nutrient.
Day laborers.
Yeah. Then you have goblet cells, and just like the name suggests, they look like little cups. They're constantly pouring out mucus to keep the whole highway lubricated.
Vital job.
Definitely.
Yeah.
And then, down at the base of the microscopic valleys, which we call crypts, you have Paneth cells. These are the local security guards.
Security guards, like fighting off bacteria.
Exactly. If a rogue bacterium gets too deep into the crypt, Paneth cells release defensins and lysozymes. These are enzymes that literally blow up bacterial cell walls.
That is so cool. And what's wild to me is how rigidly zoned their actual absorption jobs are.
Yeah.
The notes use this mnemonic to remember the zone's DJI.
Doctors just iterate.
Right, doctors just iterate. D for duodenum, J for jejunum, I for ileum. But it's so incredibly specific. The duodenum handles iron and calcium.
Yep.
The jejunum takes on folate, fat, carbs, and protein. And then the terminal ileum handles B12 and bile salts. Why is it so strict?
Well, this rigid zoning is entirely orchestrated by hormonal messengers floating through your bloodstream. For instance, secretin tells the pancreas to release bicarbonate to neutralize stomach acid the literal second it enters the duodenum.
Because stomach acid would just burn the intestine.
Exactly. Then you have CCK, which tells the gallbladder to contract and squeeze out bile to handle the fats in the jejunum. And then there's motilin, which acts as the sweeping crew.
Sweeping crew?
Yeah, it stimulates the migrating motor complex, when your stomach rumbles loudly because you haven't eaten in a while.
Yeah, my stomach growls all the time.
That's motilin. It's sweeping leftover debris down the empty tube, getting it ready for the next meal.
Okay, here's a question then. If the absorption is that strictly zoned-like, especially that terminal ileum handling B12 and bile salts, what happens if someone, say, loses their terminal ileum? Like if it has to be surgically removed?
Right. Which happens.
Does the body just, adapt? Does the jejunum suddenly learn how to absorb B12 to make up for it?
It does not. The body just permanently forgets how to process them.
Wait, permanently?
Yes. This is a crucial concept. If we connect this to the bigger picture, the gut isn't a generalized sponge where any part can just take over any job. It is a highly specific, sequenced assembly line.
So the receptors are only in that one spot?
Precisely. The chemical receptors required to grab a B12 vitamin only physically exist on the cellular walls of the terminal ileum. So if a surgeon cuts out that specific biological real estate, the patient will need B12 injections for the rest of their life.
Oh, man.
Furthermore, they'll likely suffer from chronic diarrhea because those unabsorbed bile salts will spill directly into the colon, severely irritating it. Sequence is absolutely everything here.
Wow.
Yeah.
I mean, it really highlights how fragile that perfection is. You cannot just reprogram the real estate, which actually, that brings us back to that 270-degree rotation in the womb we talked about earlier.
Right, the embryology?
Yeah. Usually that complex embryonic blueprint goes off without a hitch. But what happens when that rotation leaves a leftover piece behind?
You get what we call a Meckel's diverticulum.
Okay, what is that exactly?
So during fetal development, there's a structure called the vitellointestinal duct. It connects the gut to the yolk sac. Now, it's supposed to disappear entirely before birth, but sometimes a tiny remnant of it stays behind, creating a little blind pouch poking out of the side of the small intestine. And it's what we call a true diverticulum, meaning it's not just a thin bubble, it contains all the muscular layers of the actual bowel wall.
I was reading this part of the notes and I immediately pictured building an IKEA dresser.
An IKEA dresser. Okay, I'm following.
Yeah. You spend hours following the incredibly complex instructions, twisting things into place, and then at the very end, you find one rogue leftover screw just sitting at the bottom of the cardboard box.
Oh, yes. The leftover part.
Right. And most of the time, you just toss it in a drawer, and it sits there harmlessly forever. But occasionally, it jams the tracks of the drawer.
That is a brilliant way to visualize it. And in medicine, Meckel's is famous for something called the rule of twos. It's this fascinating statistical coincidence.
Let's hear it.
Well, it occurs in roughly 2% of the population.
Okay, 2%.
It is usually found exactly 2 feet away from the ileocecal valve, which is the door to the colon.
2 feet.
It is typically 2 inches long.
Okay, this is getting a little eerie.
It usually presents symptoms around 2 years of age with a 2-to-1 male-to-female ratio,
Wow.
and only about 2% of people who have it ever actually become symptomatic. But my favorite part is that it often contains 2 types of ectopic mucosa.
Wait, ectopic, meaning tissue growing where it absolutely shouldn't be.
Yes. Often, that little pouch contains a patch of actual stomach tissue or pancreatic tissue growing deep inside the small intestine.
But stomach tissue secretes acid. If you have stomach acid dumping into the small intestine, which, as we established, isn't built to handle it, wouldn't that burn a hole right through the wall?
Exactly. It can burn a painless ulcer right there in the bowel. That's why children with a symptomatic Meckel is often present with painless rectal bleeding.
Because of the acid burning the intestine.
Yes. And the diagnostic tool for this is incredible. It's a technetium 99-meter pertechnetate scan.
There's a mouthful.
It is. But basically, that specific radioactive tracer is actively absorbed by stomach tissue. So doctors can inject it and watch the scan literally light up a hidden, glowing patch of stomach lining in the lower right abdomen, far away from the actual stomach.
That is wild. Okay, but the notes say adults present entirely differently. They don't usually get the bleeding right. They get obstructions.
Yes, the pouch can tangle things up.
Which raises a huge question about what we do with that IKEA leftover screw. Say a surgeon is in the abdomen for something totally unrelated, like an appendix removal, and they accidentally spot a Meckel's diverticulum just sitting there harmlessly. Do they take it out?
This raises an important question, yes.
Because the notes seem to suggest age is the deciding factor. Under 50, you cut it out. Over 50, you leave it alone. Why does the age of the patient matter for a congenital pouch they've had since birth?
It's all about the surgical risk-reward calculation. If you are 30 years old, you have decades ahead of you where that pouch could suddenly decide to bleed, or worse, act as an anchor point that causes the entire bowel to twist around it and obstruct.
So it's a ticking time bomb.
Exactly. The lifetime risk warrants simply snipping it off while you are already inside the abdomen. But if you are 60, your bowel has safely adapted to that anomaly for over half a century.
Ah, I see.
The statistical risk of it suddenly causing a problem plummets. And meddling with it at that point, cutting into the bowel wall and creating a surgical join or an anastomosis, carries a much higher risk of causing a leak or creating scar tissue than simply leaving the harmless remnant alone.
Right. And speaking of scar tissue causing problems, you mentioned Meckel's can cause an obstruction in adults. That actually happens to be one of the major nightmares detailed in the pathology section of these notes.
Bowel obstructions are very serious.
Yeah, what happens when this 6-meter highway gets completely blocked? The notes refer to small bowel obstructions, or SBOs, using the ABC mnemonic.
Right, the ABCs are your main culprits here. A is for adhesions, B is for bulges, meaning hernias, and C is for cancer or Crohn's strictures.
Okay, adhesions, bulges, cancer.
Adhesions are by far the most common cause overall, specifically in patients who have had prior abdominal surgery. A bulge, or hernia, is the most common cause in someone who has a virgin abdomen, meaning they've never had a surgical incision before.
Got it. And when the highway gets blocked, the symptoms sound just agonizing. Colicky pain that comes in intense waves, vomiting, massive abdominal distension, and obstipation.
Which is the complete inability to pass gas or stool.
Right. But the presentation actually changes depending on where the traffic jam is, right?
Yeah.
If the block is proximal, high up near the duodenum, you get vomiting very early on, but less bloating.
Yes.
But if it's distal, way down in the ileum, the bowel blows up like a balloon with distension before the vomiting really kicks in.
That's just the mechanical reality of the backup. And the immediate investigation is a CT scan of the abdomen with contrast.
What are they looking for?
Doctors are looking for dilated loops of bowel and air fluid levels. On a scan, you can visually tell it's the small bowel and not the colon because the small bowel has those plicae we talked about earlier.
The circular folds?
Exactly. On an X-ray, they show up as lines running all the way across the width of the tube, almost like a stack of coins, whereas the colon's folds only go partway across.
Oh, that's a clever way to tell them apart.
But the primary goal of that scan is hunting for the absolute nightmare scenario, a closed loop obstruction.
Okay, a closed loop. That means the bowel is blocked in 2 places at once, right? So a specific segment in the middle is completely trapped with no way forward and no way back.
Exactly. And that creates a ticking clock. Because it's trapped at both ends, the gas and fluid inside that specific loop build up incredibly fast.
Like blowing up a balloon that can't pop.
Right, and the sheer physical pressure of that expansion starts crushing the blood vessels in the bowel wall. It pinches off the low-pressure veins first, and then the higher-pressure arteries.
Which means the tissue is totally cut off from oxygen.
It leads to strangulation, the tissue starts dying. And think about the cellular response there. When you do a heavy sprint and your muscles burn from lactic acid, it's because they are working without enough oxygen.
Okay, yeah.
When that trapped bowel tissue is choked of oxygen, it panics, shifts to anaerobic respiration, and pumps huge amounts of lactic acid directly into the bloodstream.
Oh, wow. So it's poisoning the blood.
That's why the clinical signs of strangulated bowel aren't just pain. It's a high fever, a racing heart rate, acidosis, and raised lactate on a blood test. If a doctor sees those signs, the patient needs an operating room immediately to save the tissue from necrosis.
That is terrifying. The notes mention another bizarre mechanical failure, though, particularly in children, called intussusception.
Ah.
This is when the bowel literally telescopes into itself like a collapsing pirate's spyglass. It comes with a very specific triad of symptoms: colicky pain, a sausage-shaped mass in the abdomen, and red currant jelly stools.
Which is essentially mucus and blood mixing together under the pressure of the telescope tissue.
It sounds awful.
It is a striking clinical picture. The ultrasound is the test of choice, looking for a target or donut sign, where the bowel walls are visibly layered inside each other. Now, the treatment difference here between children and adults is a fantastic lesson in finding the root cause.
How so?
Well, in children, it's usually idiopathic. Often, a child gets a simple viral infection, which causes those immune hubs, the Peyer's patches in the ileum we discussed, to temporarily swell up.
Okay.
The normal rhythmic squeezing of the gut grabs onto that swollen patch and accidentally drags it forward, telescoping the tube. So, doctors treat it with a pneumatic or hydrostatic reduction. They literally use a pressurized air or fluid enema to gently push the telescope bowel back out.
Just pop it back into place.
Yes, and it works 70 to 90% of the time.
That's amazing. But the notes are very explicit that in adults, intussusception always requires surgery, like unconditionally.
Always. Because an adult bowel doesn't just telescope over a swollen lymph node. There is always a lead point, a heavy physical mass dragging the tissue forward.
Like a tumor.
Exactly. In an adult, that lead point is highly likely to be a tumor, a polyp, or lipoma. You cannot just push it back with air. You have to surgically remove the underlying tumor.
Okay, so let's zoom out to standard bowel obstructions for a second. Say it's not a closed-loop emergency, and it's not a telescoped intussusception. It's just a regular obstruction caused by adhesions, scar tissue from an old surgery.
A standard SBO.
Right. The notes say the first-line treatment is conservative management. Null per os, meaning no food, an IV for fluids, and a nasogastric tube down the nose to suck out the backed-up stomach contents.
That is standard, yes.
Honestly, if there is a literal, physical roadblock in the highway, why wouldn't a surgeon immediately go in and open the patient up and clear the road? Why just wait and decompress?
I know, it seems completely counterintuitive, but think about the A in our ABCs. Adhesions, scar tissue, are the most common cause. And what causes adhesions?
Surgery.
The trauma of surgery. Every time a surgeon's scalpel cuts into the abdomen, the body heals by laying down sticky, fibrous scar tissue. If a surgeon operates today to cut away an adhesion, they are inherently creating the exact biological conditions for more adhesions to form next year.
Oh, it's a vicious cycle.
A vicious compounding cycle. What's truly incredible is the resilience of the organ itself. 70% of partial obstructions will resolve entirely on their own with just bowel rest within 48 hours.
Just by starving the patient, basically.
By emptying the stomach and stopping digestion, the gut deflates, the swelling goes down, and it often just untangles itself. The knife really is a last resort.
Wow. Okay, so we've looked at mechanical blocks like scar tissue or hernias, but we still need to talk about the C in our ABCs. What happens when the bowel's own immune system malfunctions and creates its own internal strictures? We're talking about Crohn's disease.
Crohn's is the inflammatory battlefield of the gut. It's an autoimmune condition heavily linked to smoking as a risk factor, where the body's immune system relentlessly attacks the digestive tract.
And the notes use the mnemonic CROHNS to capture its pathology, right?
Yes. C is for cobblestoning. The mucosa gets so swollen and ulcerated it looks like a cobblestone street. R is for rectal sparing, meaning it usually skips the rectum, which helps differentiate it from ulcerative colitis. O is for obstruction from those strictures we talked about.
And the S in that mnemonic stands for skip lesions, which I find wild. You can have a severely diseased, inflamed section of the bowel, and then right next to it, completely healthy, untouched tissue, followed by another disease section. It just skips around.
It does. And it doesn't just sit on the surface either. Crohn's is transmural.
Meaning full thickness.
Exactly. That means the inflammation burns through the entire thickness of the bowel wall, from the inner lining all the way to the outside, bringing this thick, creeping fat that wraps around the exterior of the intestine.
That sounds intense.
It is. Those deep, penetrating ulcers, sometimes called rose thorn ulcers because of how they look on imaging, can poke all the way through the wall, creating fistulas.
Which are abnormal tunnels, right?
Yes, a tunnel connecting the bowel to the skin, or to the bladder, or to another loop of bowel. And over years, the constant cycle of deep inflammation and healing creates rigid scar tissue, the strictures, which narrow the bowel and cause those obstructions we just talked about.
The notes also mention specific biological fingerprints to help doctors diagnose it, because Crohn's is SEA positive, while ulcerative colitis is PANCA positive. What do those acronyms actually mean for a patient?
Well, they're antibodies found in the blood. Diagnosing inflammatory bowel disease can be incredibly difficult because the symptoms overlap so much. So doctors look for these biological markers.
Okay.
SEA stands for anti-Saccharomyces cerevisiae antibodies. If a patient's blood has high levels of SEA, it's a strong fingerprint pointing toward Crohn's. The memory trick in the medical community is ACA equals all the way.
Oh, because the inflammation goes all the way through the wall.
Yes. It reminds doctors that Crohn's inflammation goes all the way through the bowel wall and can appear all the way from the mouth to the anus.
Which brings up another huge list in the notes, the extraintestinal manifestations. The mnemonic here is a PIE SAC, and it lists things like deep skin ulcers, called pyoderma gangrenosum, eye inflammation like iritis, and joint inflammation like ankylosing spondylitis.
It hits everywhere.
But how on earth does a disease of the small bowel cause your eyes to become inflamed or your joints to swell up?
Because we have to stop thinking of Crohn's purely as a digestive issue. It is a systemic immune misfire.
A whole body problem.
Exactly. The immune cells that are mistakenly attacking the lining of the gut don't just stay in the gut, they travel through the bloodstream. And unfortunately, the proteins found in the eyes, the skin, and the joints look structurally similar to the proteins in the gut lining.
Oh no, so it's cross-reacting.
Yes, the immune system cross-reacts, attacking the eyes and joints as collateral damage in its war against the bowel.
That is terrifying. It explains why the medical management relies on stepping up through heavy-duty immune suppressants, starting with steroids, then moving to targeted biologic drugs like anti-TNFs to shut down that immune response.
You have to suppress the immune system to stop the damage.
Right. But recalling our earlier conversation about the IKEA screws and surgical risk, if Crohn's creates these terrible fibrotic strictures in the bowel, why go through all those heavy drugs? Why not just have a surgeon chop out the bad skip lesions and stitch the healthy tubes together? Just cut out the problem.
It's the logical question, but if we bring this entire deep dive full circle, we have to look back at the real estate discussion we had in the histology section.
The absorption zones.
Exactly. By far, the most common site for Crohn's disease to attack, occurring in 50% of cases, is the terminal ileum. If a patient has a severe stricture there and you just surgically chop it out, what happens?
Oh, wow. We're right back to DJI. If you cut out the terminal ileum to cure the Crohn's stricture, the patient permanently loses the ability to absorb B12 and bile salts.
Precisely. You cannot sacrifice the biological real estate.
Because that doesn't grow back.
Exactly. Furthermore, because Crohn's has skip lesions, it is notorious for recurring right at the surgical connections. If you just keep cutting out diseased segments over a patient's lifetime, you will eventually leave them with short bowel syndrome. They literally won't have enough physical length of intestine left to absorb the nutrients required to survive.
Man, so what do surgeons do if they can't cut it out?
They rely on a brilliant procedure called a stricturoplasty. Instead of cutting out the narrowed tube and throwing it away, they slice the stricture lengthwise along the bowel and then sew it back up crosswise.
Just changing the shape.
Yes. It physically widens the highway without throwing away a single inch of the asphalt. Preserving the length of the bowel is the ultimate surgical directive in Crohn's.
That is incredible. I mean, it really demonstrates the immense respect the medical field has to have for this system.
Yeah.
We've journeyed all the way from that violent 270-degree embryonic twisting in the womb, down through the microscopic DJI zones of nutrient sorting.
A long journey.
It is. We've seen how rogue leftover tissues like Meckel's diverticulum can cause traffic jams, how the lack of oxygen during a closed-loop obstruction causes a dangerous lactic acid spike, and how the autoimmune warfare of Crohn's demands we widen the road rather than destroy it. It really is so much more than just a passive pipe.
It truly is. And I want to leave you with one final thought to mull over, drawing on a tiny microscopic detail we mentioned earlier.
Let's hear it.
Deep in the histological crypts of the small intestine, right next to those security guard Paneth cells, are the LGR5 positive stem cells.
The stem cells.
Right, they are the engine of this entire 6-meter highway, capable of constantly regenerating its massive cellular lining every few days. Right now, autoimmune diseases like Crohn's cause permanent fibrotic scarring. But if the small intestine inherently possesses this incredibly powerful built-in stem cell engine, could unlocking the secrets of those specific LGR5 positive cells one day allow us to command the bowel to heal itself.
That would change everything.
Could the permanent damage of these diseases eventually become completely reversible? It's a fascinating frontier.
Wow. Next time you think about your digestion, I want you to remember that.
Yeah.
You aren't just looking at a mechanical plumbing process. You are carrying around a 6-meter marvel of cellular regeneration, quietly coiled up, doing the heavy lifting for you every single day. Thanks for joining us, and we'll see you on the next Deep Dive.